Good morning, everyone. Welcome to the March 2012 Broadband Breakfast Club, maximizing U.S. health IT and broadband investments. I'd like to thank the sponsors of the Broadband Breakfast Club: Comcast, U.S. Telecom, the National Cable and Telecommunications Association, ICF International, Google, the Telecommunications Industry Association. Please give a hand to the sponsors of the Broadband Breakfast Club. I'd like to introduce the keynote for our program this morning, Sharon Gillette. She's the chief of the Wireline Competition Bureau at the Federal Communications Commission. Prior to joining the commission, Sharon served as the director of the Massachusetts Broadband Initiative, and before that headed the Massachusetts Department of Telecommunications and Cable. From 1995 to 2006, Sharon was at the Massachusetts Institute of Technology, where she engaged in academic research, program management, and teaching focused on internet and telecommunications policy, with a particular focus on broadband. She is a former software engineer and manager of Thinking Machines Corporation and BBN Communications Corps, where she worked on ARPANET computer networking technology. Please give a hand to Sharon Gillette.
Good morning, everyone, and thank you, Sylvia, for that introduction. She mentioned at the very end of my bio that I worked at BBN, and I'd like to give a shout out to Laura Breeden, who I worked with at BBN. And it's great to see so many people who've stayed in networking over the years. So that's what we're all about today. I wanted to thank you all for inviting me here to speak to you about the intersection of two of the really most important challenges for access in the 21st century: broadband and healthcare. FCC Chairman Julius Genachowski has described universal broadband access as the great infrastructure challenge of the 21st century and has led the agency's efforts to reform our universal service funding programs to raise the quality and lower the costs of broadband connectivity for rural consumers and healthcare providers, schools and libraries, and low-income Americans. Fortunately, our efforts to address the broadband infrastructure challenge have many synergies with another all-important access challenge for our nation: improving the efficient delivery of high-quality health care to all Americans, regardless of their location. This morning, I'll spend a few minutes giving you an overview of the FCC's universal service programs and some important reforms the Commission has made to these programs, with the goal of moving towards universal broadband availability. I will highlight a few of our efforts to improve broadband connectivity for rural health care providers through the establishment of a Connect America Fund, and will then focus on the FCC's rural health care program. One of the FCC's principal statutory objectives since its founding in 1934 is ensuring nationwide access to communications. Today, the Universal Service Fund is the primary means of fulfilling this goal. The fund consists of 4 programs, which together give out over $8 billion annually. The fund is financed by assessments on phone service, whether telco landline, cable voice, or wireless. Service providers typically pass that assessment along to consumers and businesses. So if you've looked at your phone bill lately, have any of you done that? You may have noticed a small fee on it. Since the release of the National Broadband Plan in 2010, we've been busy reforming each of our universal service programs to modernize them to support broadband, cut waste and inefficiency, and ensure fiscal responsibility and accountability. In addition to our rural health care program, the other 3 universal service programs are E-Rate, a program that supports the communications needs of schools and libraries. The FCC significantly reformed E-Rate in 2010, including adoption of a pilot program to test support for off-site wireless connectivity, for example, to support digital textbooks. I would just point out that program was put in place before the iPad had been first put out. Now that iPads are out, it sure looked prescient, doesn't it? Lifeline is a program to subsidize the cost of phone service for low-income individuals. Right. Ka-ching. The Commission comprehensively reformed this program last month, including approval of a pilot program to test support for broadband adoption. And last but certainly not least, a program that supported telephone networks in high-cost rural areas to ensure these areas receive reasonably comparable service to urban areas at reasonably comparable rates. And I didn't make up that language, Congress did. It's Section 254 of the Telecommunications Act, reasonably comparable service at reasonably comparable rates. In 2011, the Commission adopted a landmark order that transformed this program into a Connect America Fund. The Connect America Fund provides ongoing financial support for last-mile infrastructure for the nation, with the goal of maintaining the voice and broadband coverage we have already achieved, while targeting funds more effectively to close both fixed and mobile voice and broadband coverage gaps. Connect America adopts a number of policy innovations, including the use of reverse auctions to ensure efficient funding levels, not funding areas served by unsubsidized providers, and clearly specified obligations in return for funding. Together, these reforms will start the process of bringing broadband to the estimated 18 million Americans that today lack access. The order that the Commission adopted last fall makes clear, however, that Connecting America is not just about extending broadband for people at home and on the go, as important as personal connectivity is to the delivery of outpatient health care. The order also specifically established a goal of ensuring universal availability of broadband for homes, businesses, and community anchor institutions, including healthcare providers. Service providers are expected to engage with anchor institutions as part of their network planning to deploy broadband to unserved areas, and they'll be required to report annually on the number, names, and locations of community anchors that are newly connected to broadband. The Commission also noted its expectation that service should be provided at rates reasonably comparable to similar service offerings in urban areas. Now let me give you a little background on the various rural healthcare programs funded by Universal Service. The FCC's primary healthcare telecommunications program was mandated by the 1996 Telecommunications Act. Per the statute, this program ensures that rural healthcare providers pay no more than their urban counterparts for their telecommunications needs in the provision of healthcare services. The FCC also provides a 25% discount off the cost of monthly internet access for eligible rural healthcare providers. In 2007, the Commission created a rural healthcare pilot program designed to provide support for infrastructure to meet the needs of healthcare providers. The pilot program was, by definition, an effort to learn what works and what doesn't. The program was structured to provide funding for broadband infrastructure construction and services for a 3-year period to networks of healthcare providers. And from it, we have learned quite a bit. We've learned, for instance, that one of the greatest values of the pilot program was actually the ability of healthcare providers to work together to create statewide and regional networks that are mutually beneficial through consortia. We've learned that the process of establishing such networks can be a long and arduous road, requiring a lot of hard work and perseverance. We've learned that, in fact, most pilot participants did not spend the bulk of their funding to construct new networks of their own. Rather, where existing services are available, they've entered into arrangements with existing providers to connect healthcare facilities in a region or state. Where services weren't available, they've used consortium buying power to induce service providers to build out facilities and use strategies such as postalized pricing to ensure affordable access for all. We've also learned that these pilot project broadband networks have already provided many concrete benefits for rural patients and practitioners. For example, broadband enables rural healthcare providers and their patients to access urban medical specialists through telemedicine, such as the teleradiology, telestroke, and telepsychiatry applications that are common among our pilot projects. The Palmetto State Providers Network is located in South Carolina, and they've reported that the Department of Mental Health's telepsychiatry program delivered in excess of 7,000 consultations during an 18-month period through 22 hospitals. Not only were the patients triaged by a qualified psychiatrist, but the cost per patient encounter was significantly reduced, needless admissions were eliminated, and savings in Medicaid costs in excess of $18 million were realized. Broadband health networks also facilitate the exchange of electronic health records. All the sites for the Geisinger pilot in rural Pennsylvania have reached stage 1 meaningful use and are part of a larger health information exchange that covers 53 hospitals and 9,000 physicians. On a more prosaic, but no less important note, we learned that broadband video connections have enabled rural hospitals and clinics to access the technical expertise that's typically concentrated in urban areas, facilitating the adoption of all those electronic health records and telehealth applications. At the end of the day, though, the pilot program is simply that, a pilot. As the projects in the pilot program are now well underway, our job is to take our experience with the pilot program, as well as our years of experience with the permanent program, to help us redesign the rural healthcare program for the future. In 2010, the FCC proposed a number of changes to our permanent funding program. Since that time, we've developed a better understanding of the needs of healthcare providers, including the gaps they experience in the availability and affordability of broadband services, and how those gaps affect their adoption of connected applications. Our hope is that what we're learning will enable us to put in place an effective permanent program to support rural healthcare. Our rural healthcare team, some of whom we're fortunate to have here today, let me introduce Linda Oliver and Christy Barnhart from our team, have been hard at work analyzing the information that's been collected from our current pilot program participants and others regarding the use of broadband by healthcare providers. We've been talking to many of the pilot projects to learn as much as possible from their experiences, including today's panelist, Eric Brown, from the California Telehealth Network, which is our largest pilot program. We've been meeting with knowledgeable people in other parts of the federal government, including leaders from the Department of Health and Human Services, the Office of the National Coordinator, HRSA, and the Indian Health Service. We've also talked with folks at non-governmental organizations devoted to rural health care, such as the National Rural Health Association and at the National Rural Health Resource Center, both of which have actually provided some interesting data on rural health care connectivity. We understand that health IT applications will be a big component of the broadband needs of rural healthcare providers. We're also trying to learn as much as possible about telemedicine and other telehealth applications that require broadband capability. While we regret that Dr. Mostashari was unable to join us today to offer his insights on health IT generally, we're fortunate to have Jonathan Linkus of the American Telemedicine Association here. Unleashing the power of telemedicine is central to the intersection of broadband and healthcare. I look forward to hearing from Jonathan today, and FCC looks forward to meeting with him later this week to learn more. Through all the stakeholder discussions we're having, we continue to gain deeper insight into how the FCC's funding of broadband connectivity fits into the bigger picture of changes to health IT and healthcare in this country. We hear that we need to figure out how to simplify and streamline the existing process for obtaining funding from the Rural Healthcare Program and to reduce the administrative costs of participating in the program. Doctors and directors of rural health clinics don't have the time to figure it all out, and they don't want to spend the money to hire someone from the outside to navigate through the process either. We know that we need to ensure that our programs are working in concert with the efforts of other federal programs, including the distance learning and telemedicine program of the Rural Utilities Service, represented on our panel today by Jessica Zufalo. And as well as I just learned just before the breakfast that NTIA's Public Computing Center program that Laura is heading up runs several telemedicine pilots. Is that correct? So we can hear more about that as well. Finally, we understand that our actions need to align with broader health IT objectives, particularly those of the federal government. The National Broadband Plan focused on broadband connectivity as part of an ecosystem. Broadband networks aren't built for their own sake, even though network geeks like me might think so. Rather, they're built because each of us wants to use them to accomplish important and valuable tasks. Similarly, before the advent of meaningful use requirements related to electronic health records, healthcare providers may have had less incentive to use scarce dollars for broadband connectivity. But as meaningful use requirements phase in and create financial incentives for adoption of health IT, we fully expect increased motivation for rural healthcare providers to take advantage of our support program. So to wrap up, the FCC is very interested in helping rural healthcare providers use broadband connections as a means of providing quality healthcare to patients in rural areas and to help them take advantage of developments in telemedicine and health IT more generally. As the National Broadband Plan noted, broadband is not a panacea. However, Broadband-enabled health IT solutions offer the potential to improve healthcare outcomes while simultaneously controlling costs and extending the reach of the limited pool of healthcare professionals. Furthermore, as a major area of innovation and entrepreneurial activity, the health IT industry can serve as an engine for job creation and global competitiveness. Thank you, and I look forward to the panel discussion.
Thank you, Sharon. And now I'd like to introduce our moderator for today, Craig Settles. He's a broadband strategies consultant, author, and radio host. And for over 25 years, Craig has hosted workshops, conducted consulting services, and written books that have helped organizations worldwide use technology to cut costs, improve business operations, and increase revenue. Past clients of his include Kindred Healthcare, as well as several medical technology firms. As an author of many in-depth analytical reports, Craig is a prominent thought leader on executing effective broadband business strategies. He currently is the host of Gigabit Nation, a weekly internet radio talk show, and co-director of Communities United for Broadband, a national grassroots effort to assist communities in launching their networks. Please give a hand to Craig Settles.
Thank you. And do we have ignition? There we go. Good morning. Good morning. All right, I think they're a little dead in the back there. We seem to be alive over here. It's very nice to be here. The irony is I left California where it's actually colder than here, and my body's in severe confusion right now. But I'm happy for the warmth, wondering about the rain that came down, and hoping that the plane is able to leave later today. But while I'm here, really I'm going to be a facilitator today more so than a lecturer. And I think this is a very interesting group that's come together, and the topic is very interesting and also very significant. I think it goes without saying, I mean, for everyone that here probably realizes, we as a nation, both on the public side and on the private side, are spending a tremendous amount of money in the area of broadband and health IT and trying to make all kinds of magic happen by bringing these technologies together. I mean, just as an example, I mean, we allocated some $20 billion to facilitating healthcare, electronic records, processes, a number of initiatives for increasing broadband adoption by physicians and so forth. At the state and local level, I was reading a report the other day, it's estimated that we'll spend somewhere in the vicinity of $8-9 billion just in local areas. Again, trying to facilitate this coming together of various types of health IT and broadband. And then you can talk about all the various broadband projects, middle mile projects, last mile projects, of which health IT is a significant part of that. What's a good exercise to do at some point, preferably early and often, is to stop and assess, where are we, how far have we come, where do we go next? I mean, what I would refer to as a pause and assess moment. And I think that's basically what we're looking to have this morning, is take a little pause, see what's going on, what's been happening in various places, and give a little assessment about, how well things have worked, and then also look toward what we can be doing in the upcoming months and upcoming years. So we have a pretty killer panel here, actually. There is Sharon Gillette, who just spoke, obviously, and she's doing a lot of good stuff there with the FCC and their role in telehealth, telemedicine. Eric Brown, who, as she pointed out, is the president and CEO of California Telehealth Network, which is in its early phases. There's a lot that's going on, but basically, we're looking at sort of, a huge state a lot of challenges, but a lot of opportunities to make a significant impact. We also have Jessica Zufalo. Did I pronounce your last name right? Excellent, thank you. Who's Deputy Administrator of RUS. They were a key player in the broadband stimulus program, and I'm sure that on another time and a more relaxed note, there are some serious battle stories of being thrown into the mix there with all of that activity, all of that money that had to be, sorted out and allocated and put to work in a insanely short period of time. We also have Michael Sims, who's the CFO for Delaware Health Information Network. Now they've been around for about 5 years and have put a significant infrastructure into place to unify physicians, hospitals, labs, the various medical professionals, and also the records and the information from the patients, the people in the community, so that it's all accessible regardless of where you may happen to be if you need to take advantage of medical services, if you have an emergency and so forth. So they've got a good perspective of things that work, things that didn't work, which is also very good. Lorelei Sawick is the Director of Technology at MedStar Georgetown University Hospital, and I consider her expertise to be very good because she's been in the front line. She has been where patient meets medical facility as a nurse for a number of years, and I would say that currently, her title could also be informally Chief Cat Herder. Trying to take a myriad of paper processes and paper documents and somehow creating a system to digitize all of that and then make sure that it flows properly so that the hospital operates more effectively. And I feel like you need to get down in the trenches and talk to people there to really get an understanding of where this high level stuff, where it plays out, where patient meets doctor meets system. It's very important to have that perspective. And then also concluding our panel is Jonathan Linkus, who is the CEO for American Telemedicine Association, and they are basically the most group that is keeping tabs on, advocating for all things related to telemedicine. And so this is our group, and we should give them a hand as they take their places up here, because we're going to rock and roll. So if everybody could just come up and take their places. One of the things in consulting, I'll riff here for a moment. I often tell people the questions that are asked are almost, if not more important than the answers that you get, because by asking the right questions, you are able to come to the right answers. And a corollary to that, I just wrote a blog on this subject actually the other day, is the questions that don't get asked are sometimes also very critical, and we have to sometimes push ourselves to figure out if we're covering things. And I'm just going to give a very informal example. So everybody's probably familiar with the Titanic, the unsinkable Titanic that sunk on its first trip out. All right, that was good. That was good marketing right there. If you look at information on the design, clearly they designed the front of the boat to answer the question, what happens if we hit an iceberg? Right? Because if the Titanic had actually hit an iceberg head on, it probably would have been badly damaged, but it wouldn't have sunk. But it seems no one asked the question, well, what happens if an iceberg hits the side of the boat? And basically, the problem with the Titanic was it got hit on its side in the vulnerable part of the boat, and compartments got flooded, the ship sank, Leonardo DiCaprio and Kate Winslet became stars, sort of a 100-year legacy, if you will. But not asking those right questions is also a factor you got to look at as we examine this technology. So we're going to just jump in and ask questions, and after a little bit, we'll open up to the audience as well, because I'm sure that a lot of folks here have some questions. So what I want to start by is if we just go down the line, take about a minute or two to give the key highlights of your bio, but also talk about, you know, the main area where you see where your organization addresses that intersect between health IT and broadband. And then one last part, you know, what in this past year have you seen as like a great success story of, you know, health IT being facilitated and augmented by broadband? So we'll start with you, Sharon. Just pull the mic close. I think they're all live.
Okay, does that work? Good. Since I just spoke for 20 minutes about basically that, I will keep it very short. But I would just say that I think one of the biggest surprises to me, if you will, of the way that telehealth gets used is the importance of telepsychiatry. I don't think, 10 years ago, if you asked people what are people going to do with electronic health, they thought of like, remote surgery or, space age kinds of things. I think in some days the most mundane are the most exciting. Because, in some kinds of telework, you can, for example, so you can send an X-ray digitally, you can look at the X-ray, you don't actually need to see the patient. But in psychiatry, you need to see the patient. And so the visual, the camera, the ability to do that. Plus, it turns out that there's a big shortage of psychiatrists throughout the country. And so returning veterans, children, just getting a prescription for an ADD medication far away. I know that California Telehealth, for example, has used that application to great effect. So I think it's been interesting just to see even things that we might think of as sort of mundane or have huge impacts and great improvements to healthcare.
That's okay. Can you hear me okay? Well, good morning. I'll skip my background because it's pretty boring, but but the California Telehealth Network, as has been described, is California's statewide broadband network dedicated to healthcare. Our mission is really to use broadband technology to expand the reach of healthcare, quality healthcare, into communities with an emphasis on rural and medically underserved communities. Medically underserved, of course, we refer to generally the urban areas where there's population density, but not much in the way of healthcare providers. We are funded through the FCC's Rural Healthcare Pilot Program that Sharon alluded to earlier, which provides 85% of the cost of providing broadband service to eligible sites. Eligible sites includes primarily nonprofit healthcare providers, public or municipal healthcare facilities, county and hospitals and clinics, Native American health sites. We have all of the Native American health sites in the state of California enrolled. Federally qualified health centers, about 40% of our sites are FQHCs. We have about half of the critical access hospitals in the state currently enrolled in the program, with more on the way. In the state of California, we're blessed in that the remaining 15% of the broadband deployment costs are covered by an organization called the California Emerging Technology Fund. This was created through the California Public Utilities Commission and has a fund of about $60 million that came out of the mergers of SBC, AT&T, Verizon, MCI, I guess. In vintage California fashion, we squeezed them for money to get the merger done. Out of that $60 million, about $5 million was allocated for healthcare, which the Emerging Technology Fund has chosen to invest in the California Telehealth Network. So they provide the 15% match that is not covered by the Rural Healthcare Pilot Program. So we're one of the few states, I think, where 100% of the deployment costs are covered. And while that's good in terms of the deployment cost, the folks that work on the project, like me, have to eat. So we're fortunate that we have our money, and Gwen Weaver, who's our lead contact here in Washington, is in the room today. So we have a BTOP grant that provides, among other things, about $2 million in operating support for personnel costs, travel, a little bit of equipment, that kind of thing. It also provides for the establishment of 15 what we call broadband-enabled model communities, and these are sort of mini pilot projects that we are implementing around the state of California to prove that broadband-enabled delivery of healthcare can work. I'll talk a little bit later about what some of those applications are. There are some interesting things going on, but I do echo what Sharon said in terms of, at this stage, it's about getting broadband deployed in rural areas of California. Many of our counties, and those of you who have not been to off the beaten path in California may not realize, are really frontier, less than one person per square mile. Think about Death Valley, think about the eastern side of the Sierras. This is really the epicenter of what the California Telemedicine Network is endeavoring to do. The challenges of deploying broadband to these communities, I cannot overstate how large it is. We go to say we're going to deploy a T1 or a 10 meg circuit. We need to determine the minimum point of entry so that we can install the router. It is not uncommon for the site to say, well, what's a router? And where do I find the minimum point of entry? It is not uncommon for us to see server rooms that are carved out of old bathroom showers in the clinic because they didn't have any place else to put it. So some significant challenges just getting broadband deployed, and that's really what our focus has been over the past couple of years. I'll finish by saying we have just over 300 sites enrolled at this point. We expect to have 400 by the end of the fiscal year, by June 30. We've got about 160 connected to the network today. We expect that number to be somewhere around 300 by the end of the calendar year. As big as that is, we still have others coming to our door as they begin to figure out how broadband can help them achieve meaningful use and achieve health IT. We continue to have folks that want to enroll that we're having to put on a waiting list. So with that, I'll turn it over.
Thank you. My name is Jessica Zufolo. I work for the Rural Utility Service, and I want to thank Broadband Breakfast for putting this discussion together. It is extraordinarily timely, it's important, and I just applaud Craig and the leaders of Broadband Breakfast for putting this really terrific panel together, because it's excellent. We have a lot of leaders here on this panel and actually in the audience that really have contributed a lot to this discussion nationally and locally. I don't need to go over my bio, you guys all have it, but I want to just talk a little bit about the role that the USDA Rural Development Mission Area has in the area of health IT solutions, both from the equipment standpoint and the infrastructure standpoint. Specifically, the Rural Utility Service has had a very deep commitment, as many of you know, in financing high-speed broadband networks in rural high-cost communities. We've been doing it for 60 years. We have a program, as many of you know, the Distance Learning Telemedicine Grant Program that started in 1992, that is a very successful program that we're very proud of, that has made tremendous impacts in supporting health IT equipment and solutions in rural high-cost markets to essentially overcome the distance challenges that so many rural communities and tribal areas face in getting advanced medical care at the local level. We feel across the Rural Development Mission Area that distance should not be a barrier in receiving affordable, high-quality services that urbanized communities get that can afford it. Because we know that there's challenges in urbanized communities too, and so the Distance Learning Telemedicine Grant Program offers opportunities for grantees to utilize the grant funding to offer and provide advanced medical care as well as educational services and training to rural areas. So for example, we have a number of grantees in, I'll give an example, the Eastern Maine Medical Center provides advanced medical care throughout rural parts of Maine. So they're, again, addressing the urban-rural gap that, that this program provides opportunities to close that gap. What I want to really hope that we can do here on this panel is talk about the leveraging opportunities across the federal government and locally in addressing the cost challenges and the cost constraints that so many rural communities face. What we notice, and I think is universally known, is the extraordinarily high costs associated with getting high quality, affordable services and care in high cost rural communities. So at RUS, we have not only our distance learning telemedicine grant program. In FY11, we financed and provided to rural communities roughly $33 million in grant funding that covered 44 states. We were oversubscribed in that program substantially. We received about $61 million in requests. So again, the demand in a post-Recovery Act environment couldn't be higher. And so this is a program that can be used and has been used to offset the cost, not just of care, but also can be used with other programs too across the federal government. There's been leveraging opportunities that we talk about in the Health IT Working Group that really can be, I think, a great opportunity for rural Americans that are trying very hard, and community leaders, to figure out how best to address these gaps in service and coverage. What we also try to talk about, which I think is very important for this discussion, is not just the equipment that is so needed to deploy advanced medical services. And as Sharon and my colleagues have said, these are the applications that are available that have a tremendous success rate is in not just telepsychiatry and substance abuse and mental health training and service delivery, which is one area that we find in tribal communities so needed, but teleradiology, teledentistry, again, closing the distance gaps so that a patient doesn't have to drive 100, 200 miles to get to a hospital. I mean, that's just not really something that we want to see Americans deal with anymore. And through these programs and the DLT program, it enables that service delivery to be provided to local hospitals, health clinics, and just helping communities come up with creative solutions to receive that type of care and the type of training, nursing, skilled nursing care, skilled medical training that communities that otherwise would never have those opportunities get them. The DLT program is often a great opportunity to leverage with our infrastructure loan program that provides low-cost, low-interest financing for broadband networks in rural high-cost communities. And so this is a program that has been used for, as I said, for years, close to 60 years. It was established in 1949 off of the success of the electric program to provide solutions to close those gaps so that communities in rural America don't have to be left behind. So again, you do need a broadband connection for even DLT to even be a reality. The DLT program covers equipment, but equipment cannot be used unless you have a high-speed connection to deploy imagery. In upstate New York, we found there's just so many success stories, and I hope we can talk about them because they're really terrific, and we need to get them more out in the public domain to really not just educate the public, but educate policymakers as to ways we can really help rural Americans and unserved Americans get the types of opportunities that they deserve, but also attracting job opportunities in high-skilled nursing and high-wage jobs in these areas that really ultimately turn these rural communities into epicenters for innovation. Because we feel like there's a ton of innovation that's taking place, that has been taking place in rural America, and we just need to, I think, talk about that more and highlight those success stories. The infrastructure loan program is also leveraged with other programs across USDA Rural Development. In our state offices across America, which many of you know, and I know our state director in California, Glenda Humiston, is very committed to closing the gap in terms of providing healthcare solutions through the Community Facilities Program. That's a program that's administered across the nation by our state directors that cover the cost of the construction of a health facility, a hospital, a clinic, It can also cover the cost of equipment as well. The ways in which we need to recognize how best to leverage federal dollars couldn't be greater now more than ever. So I just wanted to stress that, and I think having opportunities like this to focus on the great work that all of our agencies are doing collaboratively is so important. Interagency coordination is something ONC has really been driving, and we just applaud it, and we really appreciate the opportunity at RUS to be part of that discussion, because we have a lot of focus on the Hill in a number of committees on health IT and really expanding those opportunities. But recognizing the cost challenges in rural communities is really important. Thank you.
Well, hello, my name is Michael Sims, and I am with the Delaware Health Information Network, or the DIN, and we are what's called a health information exchange. And so what we do is that we receive information, electronic medical results, from the labs, Quest and LabCorp, and a small local lab here in Delaware, as well as the major hospitals of the state. And all that information each comes from their proprietary systems. So everyone stores and transmits information differently. So what we do is we take all that information and we store it, and then we standardize it. We then send that information to then the different providers of the states. And so it can be the practices, your local practices. It can be the state of Delaware practices. It can be the EDs. It can be anyone who's authorized to practice medicine. And what we do is that we take that information, we standardize it, and then we assemble it into what's called a community health record. So if you have a patient who goes from hospital A and then goes to hospital B, or Dr. A to Dr. B, all that information is on different systems. So what we do is that we take all that information, and then again we compile it, and it goes into what we call a community health record. And so where that's really helpful is, let's say that you go to your primary doctor, and then he or she refers you to a specialist. Well, that you may be seeing that specialist for the first time, but they don't know anything about you. So what that specialist can do, is to go ahead and query the system. So Delaware has been in place for 5 years now. So we've been storing information for 5 years, so we have a pretty rich database. So, So where that's really helpful is, especially in emergency department settings, is where you have maybe a patient who might be under duress, or might even be unconscious. Having that information, at their fingertips is really, really helpful. My wife and I, we don't watch a whole lot of TV together, but the one thing we do watch together is Grey's Anatomy, the medical show. And I remember seeing the one episode where the head nurse said, what's the most important thing in treating a patient? And the answer was, reading the patient's medical record. And so our goal here is to assemble as much information so that when the provider sees the patient, they can give the best quality of care, limit their time in the hospital, and provide an advanced quality care. Real quick then, again, we've been around for 5 years, so we went live in 2007. And then, the stimulus package came along as well. So Delaware's a relatively small state. We have about 900,000 people in the state. We had around a $4.6 million grant. And that's been really helpful in terms of development efforts, in getting new infrastructure on board, getting new hospitals connected. One of our big landmarks that we just had is that we now have all acute care hospitals in the state of Delaware are now going to be sending information into our database. So that's just a really, really big win for us. So we're the first state in the country that's going to be able to do that. In addition, in terms of penetration on the practice and provider side, we have 87% of the providers of the state of Delaware are enrolled in using our network. So we have a real big level of penetration. We're kind of the polar opposite of Eric in California in a way. Very, very small state, but we've been doing it for 5 years. It sounds like California, herding cats is an understatement to say the least. And so we
Good to me. I don't know.
and so we love being small from that perspective. We're able to get things done relatively quickly, and for good or for bad, everybody knows each other. So so it's real helpful. So I'll turn it over to you, and then we'll go into more detail a little bit later.
Good morning. My name is Lorelei Stellwag. As Craig said, I'm the Director of Technology at MedStar Georgetown University Hospital. Georgetown is part of the MedStar Health System. Those of you from the area may be familiar with that name. We're a 9-hospital system, and we stretch from the northern Baltimore counties down to St. Mary's County. So we actually run the gamut of the urban facilities all the way down to the rural in St. Mary's. I was really pleased to be asked to be on this committee because we are actually herding cats. MedStar has about 27,000 employees, so to implement the electronic health record means bringing up to speed 27,000 people from, say, 18 years old to about 74 years old. So you run the gamut of the knowledge and the literacy of computers and what broadband is and what technology has to offer. One of the things we struggle with is the longitudinal information that we get about our patients. So right now you could be seen today at Howard University Hospital, tomorrow have the same symptoms, be taken by ambulance to Georgetown or Washington Hospital Center. We don't have any of that information. We don't know what the doctor treated for you yesterday, what medications you are on. So as Mike said, it's having that information as soon as a patient walks through the door and knowing what you've been treated for in the past. One of the greatest accomplishments that we've seen in, say, the last 2 years is the telehealth utilization for interpreters. And I know a lot of people don't think about that, but if you come into, especially in the Washington, D.C. area, you could be from Afghanistan, Kuwait, China. We don't speak all of those languages in the hospital. We now have 22-inch screen monitors that can be pulled right up to the patient's bedside. We just click, click, click out into the internet, and we have a whole cadre of interpreters, and you are speaking in your language to the interpreter, and then it's given back to the bedside clinician what you're saying, what your history is. So there's no more delay in care. So it immediately as you're brought in, if we recognize that English is not your first language, or English may be your first language and sign language, and we need to have you a signing interpreter. It's all available right on the bedside on these really nice computer screens. The other piece too is e-prescribing. So if you're seen in an emergency room, most of the time you're not feeling well when you leave. If you remember, you have to take that prescription to CVS, you have to wait in line, they tell you to come back in an hour and a half. We now have the ability to e-prescribe that right to the closest CVS to your house. So by the time that you get to that CVS, your prescription is filled. There's no more waiting for the patients. That's been a huge patient satisfaction piece for us in the direct care arena, because that is the last thing people want to do is wait for their prescriptions. One of the greatest challenges we have is what Eric said, is the actual infrastructure. So many of our hospitals are very old. We don't build new hospitals every 10 years as the technology changes. Georgetown was built back in 1956, the main part of the hospital. The infrastructure does not support our wireless routers, our repeaters. We do use old showers as closets for electrical boxes because that's where we are. So we're getting meaningful use dollars to increase our technology, but the dollars aren't there to actually improve the infrastructures of the hospitals to support that. So that's one of our biggest challenges right now.
Great. So I think, I'm John Lekes with ATA. I think in the last few years, the real change that's come about in terms of telemedicine and broadband has been a combination of things that are in front of the camera and behind the camera, and I think we've had some good examples as we go down. I like to point to radiology as one of the success stories, because radiology is a quiet behind-the-scenes activity that's transformed most hospitals. Most hospitals use teleradiology in some way. As a radiologist at 3 in the morning, they see the image at home, or they outsource some portion of their services after hours, or now about 10% of the contracts of major radiology firms are actually doing primary reads, and some hospitals are actually outsourcing everything to a group of radiologists who are not in the hospital. And patients don't see that, and it doesn't matter whether they see that or not, because you usually don't see your radiologist. The largest firm, Virtual Radiologic, did about 7 million reads last year. And so it's really transforming the way healthcare is done, but it's not what people point out saying, boy, this is telehealth, this is something, isn't this great? It's a behind-the-scenes thing. And the really transformative nature in healthcare for telemedicine is when it's not called telemedicine, when it's just a practice of care and everyone accepts it because this is just the way we do it. It's like the way you look at books through Amazon. You just download it, and now we got to the point where it's not special anymore. We kind of just do it, and you read it on a PDA, and it's really transformed the way you do retail business. And the same thing is happening with using an ATM card and everything else. Is when it's moving that way, so it's really transformative, so that's totally taken in. mHealth is another application that's received a lot of maybe more hype than reality, but nevertheless, it's a major factor that is affecting the transportability of healthcare services. When you can use FaceTime and see your doctor, if you happen to be in China, which I did, by the way, and it's seamless and it happens to be free because it was on a Wi-Fi network. That is a transformation in healthcare that's pretty dramatic. But we still have a lot of issues. We have issues with broadband deployment in some areas. We have, and I'm so glad you brought that up in terms of the internal infrastructure in hospitals, because that's one of the biggest problems we're seeing, that there's a lot of programs that'll connect a hospital with an outside world, but the problem in a lot of hospitals is the fact that they're dealing with outdated infrastructure inside, and there needs to be more support for that. There's some regulatory issues that are really very, very important, because I think telemedicine has expanded way beyond, is very fast growing outside of government programs. That's where the real expansion that we're seeing right now. I mentioned radiology, and we can mention a whole lot of other activities. But as we move away from certain things like fee-for-service programs for healthcare toward capitated systems, accountable care organizations, you're freeing up the decision-making to use telemedicine down to the provider and hospital administrator level, which is where we're going to see this expand exponentially. And then there are certain issues that we've been knocking on the door since 1993 when ATA was formed. We've been trying to get certain issues like medical licensure looked at, which has been kind of a third rail. But for the first time this year, there are several Senate offices and several members of the House of Representatives that says we need to change the laws, the way we do this, trade barriers of licensing physicians and other healthcare workers in each and every state, because healthcare now is throughout the country like broadband is throughout the country, and we need to approach it in a different way. So we're seeing certain policies opening up that we wouldn't have dreamed of in 93. We're seeing recognition, like a group like this, who all seems to, you don't have to define telemedicine, which is amazing. And we're seeing that type of transformation. But really, the real thing is when you get into the heart of providing health care. You're an intensive care unit in Alexandria Hospital, and you're being looked at by an intensivist from an office building somewhere else in Fairfax County because they're using a remote ICU. You're on a freighter in the Indian Ocean, and you have an infection of some sort, and you're being seen by a physician at GW Hospital that has a telemedicine that services that provide ships. But many people don't know that, and that's fine, because the main thing is patients are getting served, and it's all about improving healthcare and improving services. So I think that's the real miracle and the promise of where we're seeing this grow, as long as we can get the broadband deployed where we need to do it. And I'm sure the FCC is going to get that tackled this year.
Let's take a look at the issue. We're talking about success stories here. We've dipped around it a little bit. How is medical treatment and healthcare improving as medical professionals are starting to use more internet technology? So we can start anywhere, but just sort of pick out something again where you see that there is success or improvement, but not only is there, do we want to talk about the improvement, but also what's the cost? So people can start to associate certain types of applications or certain types of solutions with a dollar cost, because everybody has budgets and stuff to worry about.
Well, I'll
start.
Take
it, run with it.
Because one of the applications that we're seeing in some of our smaller communities is they are using telemedicine to allow small rural healthcare sites to have, let's say, an intensivist on call during the night. They may not have the patient population to be able to support that on their own, but through telemedicine, they can put together 3 to 5 sites that can share one resource, and it becomes viable. And we've seen instances where that has literally prevented some of these sites from going out of business because they could not have been able to afford the specialists if they didn't have telemedicine. That's one of the prime examples that I've seen that's truly transformative. And let me point out that part of the challenge of deploying broadband, and this is something that I remind people about when they look at statistics around penetration and how the money is being used and how many of the sites had broadband before versus having new build. Well, are there any NCTA people in the room? Okay, so I'm a former cable guy, right? Worked for Time Warner and for Charter. And I will tell you that all broadband is not created equal. So the poster child site within CTN for that is a hospital called Ridgecrest Hospital. Earl Ferguson is the cardiologist there. He sits on the CTN board. They had bonded T1s prior to CTN's arrival, right? I visited that hospital maybe the first week on the job about 2 years ago and tried to watch them do video conferencing just for administrative purposes. Remember, on paper they had T1s. Never was there, I visited it multiple times, won't say who the provider is, but could never sustain a connection beyond 15 minutes. It was clear when it was on, but it wasn't reliable. Now that they've transitioned to CTN, Earl is able to do consultations with patients from my office in Sacramento, and he does it reliably, okay? That's what we're talking about in terms of the transformation of care. So those are my 2 examples.
Mm-hmm. Michael, why don't you jump in, because as a CFO, I would expect that you would have both a clear view of what works, but also some of the dollar and cents issues as well.
Yeah, so again, our business model is probably analogous to maybe what you might think with Facebook or Google or something like that. So if you remember, the users of our systems are twofold. There are the people who send the information into the system, and then there are the users or the practices who retrieve information from the system. We don't charge the users anything for for being able to either receive results or to look up results. In the same way, when you use Facebook or Google, again, you're not being charged anything to use the service. And in Facebook's example, you're actually supplying the content. So in the same way, what we do is that we offer our basic services free to providers, but we charge the data centers, the hospitals and the labs, to deliver that information electronically. So I won't go into all the details, but we have a 3-tiered financial model for the data centers. And at the end of the day, the highest tier is we charge 25 cents per delivery, which is sent to a practice who agrees to turn off all their forms of manual communication. So they turn off the faxes. They don't get U.S. mail anymore, so you don't get any radiology images on the disk anymore. All those reports and stuff is available online. So one of our hospitals told us it cost them $1.80 to send a result. So once it's in their system, to extract it, prepare it, send it on its way, it costs $1.80. So it's a pretty easy cost savings that you can see there, instant return on investment there. So, so financially, that's why we did it, but also strategically, again, the only way health information exchange is going to work is if you get as many people to use the system as possible and get as many people contributing information and receiving information as possible. That's what health information exchange is all about. And so we've had really, really strong progress. As I said, we've been around for 5 years. We have 87% of the folks in the community using it. So that's been the cost savings for us there.
Now, Lorelei, I know that you're at the beginning part of your operation, but you've been at this work that you do for long enough. I'm assuming that you can kind of extrapolate out and sort of what do you expect, or maybe even early on, what are you seeing as the main benefit and what kinds of financial impacts it has.
Well, one of the first things is when you come into a facility, you want to be safe. So patient safety is at the forefront of what we do. Communication and safety go hand in hand. And one of the things that we started with MedStar Health about 3 years ago is using a small handheld device similar to what your UPS driver uses when he comes and delivers a package, but it's used for barcode scanning. We can scan you for just about anything. We can scan you, know your name and date of birth right away. If we're giving you a medication, we can scan the medication and it goes back to your health record. We know if there's any drug-to-drug interactions, if you have an allergy to something, a preservative maybe even that's in the medication. At Georgetown and through MedStar, we have seen a huge decrease, over 75% in medication error-related incidences in the past 3 years in the hospital. And that's huge because we all read what happens online when a baby is given heparin when they shouldn't be. But by using barcode scanning and medication, it has eliminated not all, not 100% the human error, but a large portion of the human error. Now, the issue is the money. The devices themselves, we purchased one from Motorola, relatively cheap if you think. It's about $1,500 between the device and the battery. It would be ideal if we could hand one to every practitioner in the hospital, which would be about 2,000 people. So, you do the math, it's just a couple $100,000 to save a life. That's where we're trying to get with this, is to get our CFOs to understand that, yes, the initial cost outlay may be a lot of money, but we're saving lives in the process, and that's what's the important piece.
Now, I'll tap on Jessica next. You've seen a lot of proposals, I'm sure. Does anything stand out in your mind as being particularly innovative or just bottom line awesome in its cost effectiveness?
Sure, Greg. There's so many great examples, and I would just urge everybody to go to the DLT website that we have on the RUS website, because that'll list all the projects that we financed last year for 2011, and will give you a sense as to the geographic diversity of these projects, the types of applications that are going to be deployed to end user customers and communities, both in tribal and non-tribal areas. I think it's really helpful for people to get a sense of what kind of creative opportunities exist and that are being put out there in the market. There's a couple that I would say really jump to my mind that kind of highlight some of the great work that's being done by rural communities. One is in rural upstate New York, Bassett Healthcare utilized the distance learning telemedicine grant program to outfit a recreational vehicle with radiology equipment, which they then drive throughout tribal communities and migrant worker communities in rural upstate New York that are very, very remote and just extraordinarily difficult to serve for any utility product, to provide services directly to the community through this RV vehicle. So they literally drive throughout these communities with this vehicle to provide prenatal care, provide obstetrical services to women in the communities near the Akwesasne Reservation, all the way up near the Canadian border. So that is just one that that we're just very proud of. But that's just one of literally hundreds of terrific examples. The South Central Foundation up in Alaska is a Native hospital that provides services to the Alaska Native communities throughout the state through distance learning telemedicine grants that we have provided them to provide services, obviously through satellite imagery that can be used by these extraordinarily remote communities throughout Alaska. And again, I can't stress enough the comments that have been made by Jonathan and others that these services cannot be made available in rural, high-cost areas without a robust broadband connection. So in the Recovery Act, what the RUS did was, one of the requirements of an award was to facilitate rural economic development. And one of those core pillars of the Recovery Act for the Broadband Initiatives Program was to provide services to the anchor institutions. And so all anchor institutions across the 300 awardees under the BIP program, and I know the same is true for the BTOP program, is to facilitate services not just on the end user side, but for anchor institutions and those that are beyond the residential community, the residential base, so that rural hospitals, rural clinics, even municipal buildings can get services that can then be sort of a redistribution point for network connection. And I'll agree with my colleague from California that speed tiers and service, the level of service is so critical in determining whether or not a rural community can actually get the kinds of advanced services that they deserve and need. We couldn't agree more. I know in the San Joaquin Valley you have a lot of challenges there, and really across America you have, a challenge where getting service to these areas is and really broadband service is so cost prohibitive given the the socioeconomic and topographic challenges. So that is why across USDA Rural Development we have not just our programs at RUS through DLT and our infrastructure loan program to finance network construction and upgrades, but the community facilities program that actually does provide funding for communities that want to renovate their hospital or renovate their health facility. So I would just encourage all of you that if you have not, and I know Mr. Linkus is very familiar with these programs, but my other colleague, panelists, colleagues, I would invite you to visit with, and I'm happy to connect you with our state directors across the nation. In Delaware, there's some great work going on, and so please take advantage of this tremendous program that's available through our sister agency at RUS, the Rural Housing Service, that deploys this program across rural high-cost areas.
Okay, I'm gonna shift tact a little bit here. Jonathan, one question I have is there, from all the things that you've observed, an economic development impact locally? I mean, we were talking about cost savings to individuals, cost savings to the medical facility, but in a rural community or even a suburban or urban community, is there some measure of success that is shown through the economic conditions or changes locally as a community?
When I started out in Washington, I worked for 10 years for something called the Appalachian Regional Commission, an economic development agency. So economic development was my real foundation. And our major investment were highways, because one of the biggest problems if you get into eastern Kentucky or West Virginia or some of the other areas was lack of access, because they couldn't get in and out. So we spent billions of dollars building these highway systems. And so if you go skiing in West Virginia, or if you go down into even through parts of Pennsylvania, you're going over a highway that was built by the Appalachian Regional Commission, because that was the way to open it up. Well, today's highways are, of course, broadband. And if you can't get access to broadband, you might as well be as isolated as you were before we built the highway system. And so, and today it's not just the wireline, but it's also the wireless. We have many areas that cannot get access to broadband communications in any way, and certainly not in wireless, which is increasingly a way of delivering healthcare. So we have seen communities ebb and flow with the basis of them being able to get access to outside areas. And I think the ability of a community to get access to affordable broadband networks, wired and wireless, is a key to a community's survival. There is just no issue. And so will it transform a community? Yeah, but will it help a community stay alive? Absolutely. It is as needed as any component you can think of.
Sharon, from your perspective of seeing a number of pilot projects underway, what's your take on the local economic development impact?
Well, I think Eric covered it very well when he was pointing out that some of these small communities, if you can't get health care in the community stops being viable, and so it really keeps the community alive to be able to have that access to healthcare. One interesting example from our world, we've been talking a lot about economics, but mostly from the institution's perspective. And I just wanted to shift gears a little and talk about it from the patient's perspective.
Right.
One of our sites, which is the South Carolina project that I mentioned earlier, the Palmetto States Providers Network. So they have a tele-OB-GYN program, and part of the motivation for this is they had done a study that correlated the patient visit to no-show rate, and they found that it was directly proportional to the price of gasoline and the distance to see a physician. So the patients are making economic calculations too, and apparently they're being able to do tele-OB-GYN, which is something we hadn't really thought about, but it has improved the high-risk care for expectant mothers who would otherwise be driving for hours, to get appropriate care. So it makes it easier, I think, for people to stay in communities if they can get decent health care from far away.
That makes sense.
Sure.
And Craig, I just want to say that's a really critical point that Sharon just made and John Linkus as well, is keeping people in these communities so they're repopulating and economically thriving centers for innovation. I think nobody on this panel would dispute the fact that rural and underserved areas have such strong potential. The agricultural output of these communities keep our urban centers fed. So we want to make sure that these are areas that actually can survive and thrive. There's, we've talked to so many high-tech companies that say, it's actually cheaper to relocate to a rural area because of the low cost in labor costs. But there's, a lot of potential innovation that we have not just seen, but continue to see. And so helping these, residential consumers of technology and of healthcare is so important, so that ultimately the costs associated with driving, as Sharon said, just miles and miles to receive high quality care is no longer really an economic viable solution for rural America. Mm-hmm. And that's something that I think everybody here is committed to solving.
Right. I think Eric wants to comment. One thing though, Eric, along with your thoughts, what kind of policy decisions might have an impact from your perspective as one who's about to build a solution? Are there any kinds of policy decisions that can make your job easier, better, more productive, what have you?
Well, I think the obvious one is the reimbursement issue, which is sort of one of the larger impediments to broad-scale adoption of telemedicine now. In California, I feel unfortunate in that we're herding cats, and there are a lot of cats in California. But the state has taken historically a very proactive, progressive attitude towards telemedicine and the adoption of the technology. Many of you may have heard that effective January of this year, we adopted new legislation, AB 415, which in large part helped level the playing field in terms of the reimbursement policies for patients that are seen by a telemedicine versus an in-person visit. It does not get us all the way there, but it's an important first step. And that was passed, by the way, with no dissenting votes in either house of either chamber of the California legislature, which is
rare.
How often does that happen?
Yeah. So I think that underscores the importance that everybody sees in that. But I think we need to go farther. We are also a state with a lot of border populations, Nevada, Arizona, Oregon. Oregon and Nevada are very active in telemedicine, renowned over in Reno, and the Oregon Health Network, which is a pilot program, partner program to the north of us. And so some of the state boundary issues around licensure and credentialing, we find ways to address it, but that needs to go away because the reality is this is turning into a global marketplace in terms of and people want to stay home, as has been mentioned. We hear that all the time when we go out in rural. It's important. I'm fortunate enough at CTN, we have the California Hospital Association as one of our stakeholders on the board, And I guess I behave well enough that I get invited to their meetings. What they talk about for the rural hospitals is how do we keep the patients in the community? That's vital to their long-term viability. And telemedicine is one of the tools, obviously, that enables them to do that. Last thing I'll say is in the area of education, it's very interesting. We are constantly asking our member sites what kinds of services and applications are most important to them. And as you've heard earlier, at the top of the list is always, can you bring me access to specialists that are not in my area? If you think about rural and underserved areas, that makes sense. Right behind that, and this was a little surprising to me, is distance education. But it makes sense. If you think about the fact that some of these sites are 3, 4, 5 hours away from a population center or a major medical center, they cannot afford to spare their precious personnel, put them in a car, lose them for a day or two, let alone the expense of getting them to wherever the training might be. So we partner with, right now, the University of California Medical Centers, the California Education Corporation for Educational and Network Initiatives in California, CENIC, which is the statewide organization that provides broadband to the educational institutions, all the University of California campuses, K through 12, community colleges. So we're plugging into that because the educational and CME arena is another key benefit that we can provide that saves these sites a lot of money, or more importantly, might enable people to participate in trainings that they ordinarily would not be able to.
Let me run one question by Michael, Lorelei, and Jonathan, and maybe if we have time, we can get a question or two from the audience. What has been, to date, your biggest challenge, or in Jonathan's case, what do you see as maybe a general challenge across the board to getting the things done that you need to get done? Is it money? Is it policy? Is it legislation? What's the challenge you got? We'll start with Michael.
So for us, HIEs, or health information exchanges, are a pretty new breed. I think we're probably about the oldest in the country, or close to it, 5 years old. As I mentioned before, we received a stimulus money. We received $4.6 million, and there was $565 million, I believe, set aside, which were given to each of the states and territories, really for most states just to establish and to create the infrastructure and the connectivity for a health information exchange. That grant, is going to dry up September 2013 or maybe February 2014, and you still have a lot of states who are still developing things. So the biggest challenge a lot of states see, we've been up and running, so we're actually relatively sustainable. But the biggest challenge that our health information exchanges are going to see is how are they going to value their products and services, so that after the seed money, the venture money, runs out, how are they going to be sustainable? And going back to policy real quick, I think how you do that, and I wish Farzad was here today, is what this stimulus package has done for electronic medical information is incented the doctors to go out and buy what's called electronic medical records, which are computer files which replace these things that you see. So it's incented them to buy them, but there hasn't been enough emphasis yet on the exchange of information. So when you go into a doctor's office, they take their notes or they talk into their dictaphone. All that stuff is staying in-house. It's not being exchanged. So how we can be helped out, and how the other health information exchanges in the country, again, who are looking to get sustainable, ongoing growth, again, is to really incent doctors, just like they did with the electronic medical records, incent doctors to exchange the information.
I think one of the failures of the incentives was that there are several companies out there, Cerner, Epic, Siemens, that are building these platforms, and they don't speak to one another. It's all proprietary. So there's really not the ease exchange of information that we would have hoped come out of a meaningful use. We're still operating in silos, And as I was telling Mike before at the table, at Georgetown, we have one system inpatient, outpatient has a completely different system. You could be in the clinic right now and the doctor say, okay, you need to go to the emergency room immediately, and the two systems don't talk to one another. So they're still bringing a piece of paper with them just down a couple of floors. That's been a huge impact in the hospitals, is yes, the incentives are out there and physician practices have embraced them and hospital systems are trying to embrace them, but we're just on completely different platforms. And I think by policy, had we looked at the platform that the VA system uses, that they've had in practice for several years, and more thoughtfully implemented that system across the country, we wouldn't have the disparities in the exchange of information that we have now. That's really a key in the hospitals.
Interesting. And Jonathan, your
So,
review.
yeah, I think in terms of some of the biggest challenge that we have right now and the financial issues, some of it, there's certainly reimbursement, and there's a real lack of understanding by federal policymakers in terms of the importance of that. So, for example, in reimbursement for Medicare, there's fortunately, despite the fact that the federal government hasn't been a leader in this, there's 10 to 15 million Americans that are getting services remotely. But in reimbursement for Medicare, for telehealth services, is practically not there. There's about $3 million spent a year in reimbursement for interactive video. Teleradiology, other images, fine, no problem. But for that, $3 million compared to $77 billion of spending on a system of trying to get people to adopt electronic records. I think that's a real problem. There's a real issue with that. There's a lack of understanding. There's the biggest challenge we have coming down the pike is remote monitoring in the home. That's where we have 30 to 40 million Americans that are coming up as chronic care patients, and yet we have no way whatsoever of handling that issue. There's no reimbursement pattern, nothing been thought through, and there's been a tremendous amount of resistance by the federal government in moving in that direction. That's the biggest issue. In terms of electronic medical records, I've got to add my 2 cents to this, and I'm a little bit of a lightning rod on this. I'm sorry, but I believe the system that we have in place has been an arrogant design. I think it is not designed to really look at the needs of the patients or the consumers. There is a fundamental flaw in it which is fatal. So I think we need to completely rethink where we're going with the electronic patient records. It's a real big problem that has not come home to roost, but I suspect will very shortly.
Interesting. So,
Say what that problem is.
It's a top-down approach toward designing the system with a lot of money that's thrown into the system to try to buy off doctors and hospitals to do something they don't really want to do. Every time it's been implemented, and I can go to every hospital system, and I have talked to physicians in every hospital system in the Washington area, and the horror stories you're getting out of them is unbelievable. There is a system that was just put in place in one hospital, not yours, for which doctors actually walked off the job when it was being put in because it was done so horribly. There is this emphasis on, we need to get this in place, but they're completely lacking the fact that there are different systems and different networks. Hospitals want to compete with each other. They don't want to share information. It's against their economic interest to do that. And there are firewalls put in place. So you might have a system that can communicate with each other according to the federal law, but they're not going to because there's firewalls that will prohibit them to do that. So there's a lot of incentives that are not there. If you look at the way the communications industry has done it, you look at the way banking has done it, you look at the way music industry and books have done electronic networks, completely different design with a consumer interest and consumer focus, not in healthcare. It's a real lack in terms of it. And with the healthcare system that's put in place for electronic records, there's added to that a lot of requirements that are changing the way certain people at the top level feel like doctors at the lower level need to behave. And that's an arrogance in the system that has to change.
And to add to that, at the clinics level, which is where a lot of my clientele are, you just multiply that exponentially because they're all dealing with multiple hospitals. If I'm a FQHC out in the Eastern Sierras, I might send some of my patient power deals somewhat with UC Davis or with Renown. And both of them are on a particular, I won't say which one, EHR system, but they're on different versions, and they don't talk to each other. So here you are, less than 20% of my sites have on-site IT resources. Less than 20%. They're at the mercy, And so this is this is the outcry we get in California is, can't we do something so that we have an EHR platform that's interoperable, that if I'm dealing with a patient that's coming from a different system, I can exchange information. And it's a tense situation right now, but we got to break through that. So
I'm going to interject actually my own little thought about along the lines of what Jonathan said. One of my consistent criticisms or critiques in my writings, blogs, and so forth has been, I feel like there isn't a community-driven design of solutions which the government then facilitates, as opposed to everybody's trying to fit into set pegs and circles, and it doesn't work very well because there is such a diversity of people and needs and organizations, and so better to have some general criteria, but let the communities take a stronger design role in the process. And this is not just telehealth, but I think it is we're helping from a federal level, but we need to rethink, I think, philosophy that kind of dates back a few years. I think the people, we see a lot of people who are trying to do that from within the government, but at the same time, I think if we can push for their bosses, to really rethink things, it'll be much better. So do we have any questions from I'll work with you first.
This is Alice Borelli from Intel, and John, I couldn't second what you said any stronger. That was very well put. And it's so nice to see an old friend, Jessica, sitting up there. I haven't seen you for a long time. But here's my question. The FCC, NTIA, RUS, you've all had some really great experience. You've had significant funding to put into effect to change the way healthcare has been delivered. We now have CMS, and CMS spends one out of almost every $4 taxpayer dollars, 22% of our budget. And they are launching on an innovation campaign through the Innovation Center with $10 billion to spend. Have you talked with them? Have you shared your success stories? Is there a formal or informal way to share what you've learned?
Sure. Thank you, Alice. That's great to see you as well. Yes, the administration is very committed to interagency coordination, and we've been doing that. The RUS, FCC, NTIA, and all of our federal agency partners across the government that touch technology, telecommunications, and health in one way or another are very active on the Health IT Task Force. We have calls and meetings almost weekly to not just harmonize the work we do, alert our federal partners of the programs we administer to try to help figure out how best to help patients and consumers participate in these programs. CMS does great work, and through the offices of Mr. Mustashari, we are very engaged, all of us, in discussing and working collaboratively to leverage those dollars with all the pilot program at the FCC, with the DLT program, community facilities, and so forth, to really deliver them effectively, smartly, and quickly, because we feel that the patients across urban and rural areas deserve high quality care. And actually, I would just say that the interoperable challenges that we're talking about today is exactly the kind of issue that the Health IT Task Force is focused on addressing.
I think there was a question over here. Yes. Just speak up. It's a small group. I think we can hear you.
Yes. Hi, I'm John Wimphausen. I'm the director of the Schools, Health, and Libraries Broadband Coalition. And that name is relevant to my question because the National Broadband Plan talked about the virtues of sharing networks and having all the anchor institutions together on a common shared broadband network that would make it more efficient, easier to then expand that network out into these rural areas. And yet I'm still hearing a little bit of focus here, but correct me if I'm wrong, is there a need for a separate health network that that is distinct from the broadband networks that can be used by the schools, the libraries, and public safety and other anchor institutions. So that's sort of my question for the health representatives. My question for Sharon and maybe Jessica too is, I had thought perhaps the FCC was going to try to roll the rural health broadband reform programs into the Connect America Fund to try to reflect that philosophy of sharing the networks. You shouldn't have standalone health networks separate from what the schools and libraries are using. So I'm wondering if we can move in that direction, or is that just too much for the health community to consider sharing networks with other anchor institutions?
Perhaps it was too subtle in my speech. But what I was trying to say is that the Connect America Fund is about that shared infrastructure. And so we're looking at it as a way to build out the infrastructure in the community that everybody shares. That said, there's a lot more to first of all, they're going to be, so part of what I was trying to explain in the speech is that we had provisions in the Connect America Fund for some of those community anchor institutions. We're not the only one in that space. Obviously, BIP and BTOP had a great deal of effect on community anchor institutions and a mandate to reach out and serve them. So I think the point that you're making, which is, are we building networks, physical networks only for healthcare? Are we building networks for communities which healthcare uses? I think across the government, I think people have heard the latter. So I get that. I get that point. That said, I think it's been amply demonstrated by the panel, there are unique needs in the healthcare space, and the interoperability issues go way beyond sharing the physical network. I think, from what I'm hearing, the interoperability challenges are largely at what us network geeks would call higher layers of the protocol stack. Michael has spoken about, needing to take a record from two different providers and translate them into a common format. Elliot Maxwell's here. He's, like me, been in the internet space a long time. Will recognize, to me, that's what IP does in the network, in the physical networking space, right? It takes one networking standard and another, and it bridges and translates them. And that's what I gather the Health Information Exchange is doing at the application layer. It's taking the data and turning it into that. I also understand, though, that in order to do that with medical information, it's extremely complicated. There are, as some of my medical friends have said, there's a zillion different ways to stub your toe, it turns out. There's a lot of different ways that information about a person's health condition can be represented, coded, and so forth. So getting that to be interoperable is quite complicated, and I think very specific to the needs of healthcare from what I understand. I think our healthcare people could probably address that better than our connectivity people here. So maybe
okay.
Ask one.
Yeah, we're out of time, though. I know that we are on a roll, and there's a lot more questions out there. But I don't want us to back up the folks behind us, and I get a bill or something. But this has been, I think, a very good exchange of information. I want to give definitely a hand to Broadband Breakfast for hosting, to all of the sponsors whose support makes these events possible, and obviously for our panel, who are truly awesome folks who know their stuff. So let's give it up for the panel. There you go. And when you see Titanic 3D, remember, it's the unasked questions. Those are the questions. That's what gets you sometimes. All right.
Stay tuned for the April Broadband Breakfast Club. We may have a change in topic. And I just want to thank again the sponsors, Comcast, US Telecom, NCTA, ICF International, Google, and TIA. Thank you all for coming.